Asian Council of Hypertension of Asian Heart Society. I'm Jing Liu from Peking University People's Hospital. It's my pleasure to give a talk about management of nocturnal hypertension. Nocturnal hypertension is usually defined as nighttime blood pressure more than 120 over 70 millimeter of mercury in ambulatory blood pressure measurement, regardless of nighttime BP dipping patterns or daytime blood pressure. In the past decades, we can see some epidemiology study has demonstrated that prevalence of nocturnal hypertension is a little bit higher in Chinese, in Japanese, or other Asian populations than the Caucasians. And also there is many studies demonstrated that nocturnal hypertension is more associated with cardiovascular target morbidity and mortality, which is also independent of daytime blood pressure. As we all know that the ambulatory blood pressure is not always accessible in daily practice. We can see that nocturnal hypertension is usually underdiagnosed and let the patients exposed to higher cardiovascular risk. In past, there is no guidance on how to and when to treat nocturnal hypertension. Just about 2 years before, I and Professor Jiguang Wang initiated expert consensus document writing, and Professor Yan Li from Shanghai and Professor Xinjun Zhang and I are writing group members. You can see the picture that we have several rounds of the consensus document discussion with more than 50 experts across China, and after 1 year's journey of the consensus discussion and writing and submission, finally this document was published in this year's Journal of Clinical Hypertension. I and Jiguang Wang are corresponding authors of this document. Because there is no guidance previous in this field, so in this consensus document, we have entire content, including the definition and epidemiology of nocturnal hypertension, as well as pathophysiology, clinical phenotypes, target organ damage, and cardiovascular complications. We also mentioned in detail about how to diagnose and monitoring the blood pressure in this population, in this situation. We also write in the detail for the treatment of nocturnal hypertension. One of the highlights of this consensus paper is we also propose the unsolved problems and the future directions for research and study of the nocturnal hypertension. And finally, we form the recommendations for the management of nocturnal hypertension. I will give a brief introduction of the highlights of this documents. As I mentioned before, that in the past, some epidemiology studies have demonstrated nocturnal hypertension is a little bit more prevalent in Asian populations than in the Eastern or Western Europeans. This data is from international database for ambulatory blood pressure measurement, we can see even for the sub phenotype of nocturnal hypertension, and we means here is isolated nocturnal hypertension. We can see in Chinese or Japanese, the instance of prevalence of isolated nocturnal hypertension is a little bit more than the Europeans. This may be due to the high salt intake or high salt sensitivity in Asian population. At the same time, just as Professor Verma mentioned, that in the Asian population, the sympathetic nervous overdrive may be one of the contributors for the hypertension increasement in Asian populations. This is also true for the pathophysiology of nocturnal hypertension in Chinese population. We can see from the different studies that in different populations, such as patients with chronic kidney disease, those with diabetes, those in the elderly, and the patients with complicated with obstructive sleep apnea, more than 50 or even reach to 70% of this population or special conditions are accompanied with nocturnal hypertension. From this document, we have proposed several pathophysiology of the nocturnal hypertension. One is the Guyton's theory about the pressure natriuresis, because the high salt intake or high salt sensitivity, the blood pressure need to raise blood pressure in day or in night to make more salt to excretion from the kidney. The other mechanism may be involved, the increased circulatory volume and increased sympathetic activity at night. Some patients are complicated with OSAS. We can also see nocturnal hypertension in the some aging people, or even those with fragile. We can see that decreased blood pressure auto-regulation capacity maybe exists in this special condition. And also some patients with secondary hypertension, such as primary aldosteronism, are also demonstrated as nocturnal hypertension. One point should mention here that we can see from the left of the picture that patients with nocturnal hypertension are always demonstrated as non-deeper or reverse deepers. But this was two different conditions. They were overlapping in most of the situation, but they are different concepts, because even for some people diagnosed with nocturnal hypertension, they can also demonstrate it as deepers. In this document, we have defined three phenotypes of nocturnal hypertension. That is, the first is a day-night sustained hypertension, which means that the daytime blood pressure is more than 135/85, and at the same time, the nocturnal BP are more than 120 over 70 millimeter of mercury. The second phenotype is isolated nocturnal hypertension, which is a phenomenon first proposed by Professor Jigong Wang and Yan Li. That means nocturnal blood pressure more than 120 over 70, while the daytime blood pressure is less than 135 over 85 of millimeter of mercury in the ambulatory blood pressure measurement. We can say in the clinical practice that many hypertension patients are received BP lowering agents. In those treated with antihypertensive medications, if the patient's daytime blood pressure is controlled, while their nocturnal blood pressure is still above 120 over 70 millimeter of mercury, this could attribute to uncontrolled nocturnal hypertension. As for the diagnosis and monitoring of nocturnal hypertension, just as Professor Verma mentioned in the Indian's guideline, and also Professor Jigong Wang demonstrated of the next coming new Chinese hypertension guideline, that the 24-hour ambulatory blood pressure measurement is still the gold standard for diagnosis of nocturnal hypertension. But just as I have asked the questions, as some newly developed electronic upper arm or variable rest type blood pressure monitoring include some watch type new smart wearable devices of BP measurements. We can also use them for the home blood pressure monitoring at night, but only those validated or accordance to the international standard devices could be recommended in these situations. Recently, some companies such as Omron or Huawei in China has several type of such a product provided into the market. So the subjects or patients could make a different choice if available. As for the treatment of nocturnal hypertension, we emphasize that lifestyle changes are still the basis for the nocturnal hypertension blood pressure control. And we strongly recommended use long-acting BP lowering agents at full dose or in combination therapy. We also mentioned that some special BP lowering agents have demonstrated the advantage of nighttime blood pressure reduction with clear evidence. Those drugs could be recommended as a special choice if the drugs are accessible or available. We after several rounds of discussion, we reach agreements that the mean nighttime blood pressure should be controlled below 120 over 70 millimeter of mercury for general population of with nocturnal hypertension. But those in the elderly or those with coronary artery disease or complicated with other conditions, the blood pressure target should be adjust individualized. We can see in this document, we emphasize the salt intake restriction should be strictly restricted to less 5 gram per day, and in patients with chronic kidney disease, or those with heart failure, diabetes, ulcers, or with autonomic nervous dysfunction, and in some conditions of secondary hypertension, effective treatment should be given for the primary disease. At the same time, we need to carefully evaluation and intervention the fluid overload, especially for those with high salt intake or those with high salt sensitivity. And in some patients, such as beta blockers are also indicated in patients with sympathetic activations. And in the people accompanying with OSAS, if the CPAP is available, they are recommended to improve hypoxia, and at the same time, it will be help to improve the nighttime blood pressure control. The long-acting antihypertensive medications are strongly recommended in this consensus document because these long-acting medications are usually used in the daytime or in the early morning, but their blood pressure lowering effects can extend to the night or even for lasting for 24 hours. But in the clinical practice or real world, we can see some doctors will choose some medications with half-life less than 6 to 8 hours. We can see from the table, we can, for example, if we use different herbs, not every herbs have the ability to control nighttime blood pressure if they were dosing at the daytime or in the morning. Only those such as alisatan, telmisartan, irbesartan, or olmesartan with half-life more than 8 hours. Usually, these drugs could be used once daily for 24 hours blood pressure control. If we choose losartan or valsartan, in some situations, these drugs usually needed to be used twice daily to reach the target of nocturnal BP control. One should mention here is chronotherapy. Actually, this is a very interesting field in the management of hypertension, especially for the nighttime BP control. And also, there is many studies investigated the chronotherapy and the effects on the nocturnal BP reduction, as well as blood pressure circadian restoration. But the results from different investigating groups are not always the same, and in sometimes they were even for different, very different or conflict results. So after retrieval the different literature published before this document was formulated, we can draw a conclusion and that currently we not routine recommended to use blood pressure medication, lowering medications at night. These recommendations are also in line with International Society of Hypertension recent published consensus paper. In those papers, they also recommended long-acting BP lowering agents to be taken once in the morning as a usual care to achieve 24-hour BP control, and bedtime medication or dosing were not routinely recommended. But we all know that there is several clinical studies, especially for those focused on cardiovascular outcome, are still ongoing. We are expecting these clinical studies or trials will give us a more clear answer for chronotherapy using in nocturnal BP control. As for the innovative drugs, we can see, just as Jiguang Wang mentioned, that new herbs innovated by Chinese expert named alisatan isoproxil has finished several phase 2, phase 3, and also, as well as post marketing study. This study demonstrated that alisatan have the advantage of nighttime blood pressure reduction, or even more than daytime BP lowering. So in this consensus paper, we have gave a detailed describing the study and the result, and gave the prudent recommendation for use of such innovative drugs. The second one is ARNI, because Professor Jiguang Wang has given us many reasons why Chinese hypertension guideline has recommended ARNI as first-line BP lowering agents. As for the nocturnal BP control, ARNI also have good presentations. In some studies, we can see that the sacubitril valsartan 20 milligram per day reduce nighttime even more than daytime reduction. In the near future, we also have sacubitril alisatans compounds will put into the market. So we also expected to have such a agent to be used with potential to nocturnal BP reduction. The third one is a new generation of mineral corticoid receptor antagonist named xalrenol. In some studies, they also demonstrated that this new generation of MRA have also the ability of the nighttime BP reduction with a very lower instance of adverse events. The fourth one with nighttime BP lowering potential is SGLT2 inhibitors, including canagliflozin, empagliflozin, and dapagliflozin. In the meta-analysis involved these very popular SGLT2 inhibitors as compared with placebo, those SGLT2 inhibitors also demonstrated some extent of nighttime BP reduction in patients with type 2 diabetes and hypertension. The fifth one is endothelin receptor ETA, ETB antagonist aprocitentan, because in the recent study named the Precision study published in New England Journal of Medicine, aprocitentan also demonstrated the advantage of BP control and with very lower incidence of adverse events, and most of people could tolerate these new drugs. In some study also demonstrated that aprocitentan 15.5 milligram per day or 25 milligram per day for 4 weeks can reduce daytime blood pressure by nearly 4 millimeter mercury, and the nighttime blood pressure by 5.1 to even more than 7 millimeter mercury, more than placebo. So these drugs also could be used if they are put into the Chinese market. In this document, we have a detailed statement of the Anzhou problems and the future directions for nocturnal blood pressure measurement. Because in some phenotype of nocturnal hypertension, there are still many problems to be resolved in the near future, such as for isolated nocturnal hypertension, in addition to ABPM, how can HBPM, especially just mentioned the smart wearable devices, play a role, and what is the best treatment target and interventional strategy for these special conditions. There is up till now no head-to-head comparison study to demonstrate the benefit of a different class of blood pressure lowering agents for nocturnal BP control, or even for the cardiovascular protection. And finally, we have reached 8 recommendations for management of nocturnal hypertension. These are involved in the definition of nocturnal hypertension and how to diagnose nocturnal hypertension with 24-hour ambulatory blood pressure measurement, or in those special populations who are prone to nocturnal hypertension, such as those with old age, obesity, diabetes, and with CKD or OSAS, and as well as some disorders. We also recommended use home blood pressure monitoring devices, including smart wearable devices, but they should be validated with standardized and also could be recommended for routine follow-up in patients with nocturnal hypertension. The nocturnal BP should be controlled in 120 over 70 millimeter of mercury in most of the people, but in those with CKD, CAD, or in the elderly, the individualized blood pressure target should be adopted. Lifestyle changes, especially should address the lower sodium diet and appropriate potassium supplement are very important for nocturnal blood pressure control. if the patient with sleep disorders or OSAS, the primary disease should be treated or controlled properly. And as for the medications choice, we recommended long-acting blood pressure lowering medications be used maximally tolerated dose or combined with 2 or more drugs of different mechanisms to achieve nighttime BP control. As the last and some new drugs with nighttime BP reduction property are also preferred if available. This is the summary of our consensus document because this is the first document on how to and when to treat or manage of the nocturnal hypertension. So we provided a systemic recommendation on the suggestions in this document. And we also defined a clinical phenotype of nocturnal hypertension and provide the standardized diagnosis and treatment procedures, and give a recommendation for clinical management of nocturnal hypertension. Long-acting BP lowering agents and some innovative drugs with nocturnal BP reduction property are recommended in this expert consensus document. That's all for my presentation. Thank you. Thank you very much.